All right, I'm going to go ahead and kick things fully off. We have one presentation during this session. They're going to be presenting for about 30 minutes, and then there will be 10 minutes for Q&A afterward. I'm excited to moderate this presentation that is exploring unhoused patients excluded in our current substance use surveillance framework. Our presenters will discuss the descriptive analysis they use to better understand this underrepresented population. I'm now going to turn it over to Kylie, who will present on unhoused patient zip codes and Z chapter ICD-10-CM codes in the Colorado Emergency Department visit data. This is a descriptive analysis of demographic and clinical variables. All right.
Thank you so much. Hello, everyone. It is so great to be here with you all today. I'm feeling very energized from this morning's sessions, and I don't know, when I read the description for this year's conference, I thought that this analysis project I worked on fit really nicely into the idea of things. So without further ado, my name is Kylie Yoakum, and I am the drug epidemiologist at the Colorado Department of Public Health and Environment's Prevention Services Division. One of my main responsibilities in this role is analyzing data related to non-fatal overdose and healthcare visits associated with substance use disorders. Today, I'll be discussing an analysis I ran recently to integrate data for persons experiencing homelessness in our ED data using an unhoused patient zip code indicator and certain Z chapter ICD-10-CM codes in Colorado. First, we'll begin with a little background. Data for this analysis and the work that I do related to non-fatal overdose and substance use disorders come from the Colorado Hospital Association, and it's an administrative billing data set on hospital and emergency department discharges from member hospitals in Colorado. And when I say member hospitals, notably, this does not include federal health facilities such as the VA, for example. Unless otherwise specified, the ICD-10-CM diagnosis codes are from any of the 30 diagnosis code fields from this data set, though there's some certain analyses where I focus specifically on the primary diagnosis code, which would be the primary reason that the patient was in for a visit. And then notably here in Colorado, we have a designated 5-digit zip code to indicate that a patient is unhoused for this billing data set. It's that 00003 zip code. This will likely be an undercount due to varying states of housing instability, such as couch surfing or staying in a shelter where there's an address provided. And then additionally, starting in October 2015, they introduced ICD-10-CM codes for social determinants of health that were impacting the current healthcare visit. I'll refer to these as SDOH, or Social Determinant of Health Z codes, throughout this presentation, as they come from the Z chapter of ICD-10-CM. And I'll go more into detail on that in the next slide. Using the two of these indicators, we created a new definition for the non-fatal overdose surveillance dataset for persons experiencing homelessness. And I may also refer to that definition as PEH, as the acronym. Here's some additional information about the Social Determinant of Health Z code chapter in ICD-10-CM. Social determinants of health are the conditions in one's environment where people are born, live, learn, work, play, pray, and age that affect a wide variety of health and quality of life outcomes. And this is the field to indicate factors influencing the current health status that are not classifiable elsewhere as diseases, injuries, or external causes for that billing dataset purpose. And here's a little bit further explanation of the different chapters in the Z code categories. Problems related to education and literacy, employment and unemployment, problems related to physical environment, housing and economic circumstances, which is what we'll be focusing on today. Problems related to social environment, upbringing, and other primary support groups, other circumstances, and occupational exposures. So really encompasses a wide variety of circumstances, though some are certainly more prevalent than others. The Z59 codes that we'll be focusing on for the purposes of this analysis and the presentation include homelessness, whether it's sheltered, unsheltered, or unspecified, as well as inadequate housing, such as environmental temperature or inadequate housing utilities. And they also include folks with housing instability, with a risk of homelessness, or with a recent history of homelessness. So quite a wide variety of circumstances as well, even within that category. And now we'll dive into the data a bit. This table shows the frequency or prevalence of that unhoused patient zip code indicator over the years from 2021 through 2024. You'll see that the zip code represents about 1% of total ED visits, and that 1% represents about 20,000 visits every year. So after running that frequency analysis of that unhoused patient zip code indicator within my existing surveillance data set, I wanted to analyze the prevalence among this group of that Z59 ICD-10-CM code of problems related to housing and economic circumstances, which you'll remember captures a wide variety of housing instability. However, I ran into a confusing issue when I started running this analysis. And when I tried that frequency analysis with both variables, I ended up with 0 observations in my millions of records in the ED visit file that had both the unhoused patient zip code indicator and the ICD-10-CM code for problems related to housing and economic circumstances. And this didn't make sense to me. I certainly didn't expect every record to have both. Or if a record had one, that it would have the other, but I certainly didn't expect 0 records. So I dug a little bit further. And then another problem arose. After integrating the unhoused patient zip code indicator into my existing data set, every single one of these values were filtered out, and there were 0 observations in my data set that even had that unhoused patient zip code indicator that I just previously showed. There were 20 tens of thousands, 20,000. And, in this data set, I ran my usual exclusion criteria, but in my mind, it wasn't anything that would be coming up with no results. Some of these exclusion criteria include excluding patients with a discharge status of deceased, or excluding patients who are discharged to rehab hospital, that type of thing. So after both of these analysis fails, I can only describe my problem-solving process as akin to tearing apart every single room in my house when I was trying to find my keys and I'm already running late. I don't know if anyone experiences that kind of panic and confusion in that circumstance, but the results didn't make any sense to me. And so I'm going through every single variable in this data set and running exploratory analyses on every single one, digging everything out of my data closet, so to speak, to try to figure out what the issue was. And after some collaboration with other folks in the health department who regularly use this data set, it turned out that my issue, and then an issue that other folks were running into, was this variable, store. And in hindsight, it makes sense what it was. It's state of residence equals 1. And it's formatted a bit similarly to our county of residence variable. So hindsight's 2020, and I get that now, but I was reaching out to a lot of folks. It wasn't explicitly mentioned in our coding data set. And so just one of those things where you want to be extra crystal clear on. And as I researched this variable, it turns out that the state of residence variable was either 1 or null. And so obviously the null indicator, or the null records, were excluded from this statement. And it also turned out that the patients with that unhoused patient zip code indicator rarely and usually never had geographic information, which resulted in the state of residence variable being null, resulted in the county variable being null, FIPS codes being null. Every single geographic variable just had nothing. So this is obviously a large cascading effect within our data set when it comes to geographic information. But for the purposes of this analysis, moving forward, I revised this line to include this state of residence equals 1 or the unhoused patient zip code equals 1, so that our unhoused patient zip code indicator subset was still included in the surveillance infrastructure despite incomplete information for the geographic records or the geographic variables. After this correction, we could finally see the trend line rather than a null output. So let's dive into those results. After troubleshooting, it turned out that thousands of the patients with the unhoused zip code indicator also had that Z59 chapter code of ICD-10-CM, anywhere from about 4,000 to about 6,000 every year. When I was analyzing these results, however, I did see that not all patients with the unhoused zip code had the Z59 housing instability code, and vice versa, which I'll dive into later in this presentation. So looking at our unhoused patient zip code data subset, here are the 5 most common primary diagnosis codes among that data subset. Many patients, or the majority of patients, had a primary diagnosis code of R45.851, which is code for suicidal ideations. And the next 3 codes are substance related. The alcohol chapter of F10 for documented use disorder shows up in the next most common codes: alcohol abuse with intoxication, both uncomplicated and unspecified. The next one on the list is for other stimulant abuse uncomplicated, which would encapsulate amphetamine and methamphetamine use disorders. And then here are the 5 most common discharge status codes for those unhoused patient zip code indicator dataset from 2021 to 2024. You may remember me mentioning earlier that patients with a discharge status of deceased are excluded from records. So this is just our non-fatal ED visit subset, just for the record, but these are the 5 most common discharge status codes. The majority, 83.5%, had routine discharge to home or self-care, with the next most prevalent code being discharged or transferred to court or law enforcement, a little over 6.5%. Other common discharge codes include being discharged or transferred to another undefined type of healthcare institution within this list, and discharge or transfer to a psychiatric hospital or a psychiatric distinct unit within the hospital. It's about 3.5%. About a little over 2% left against medical advice or discontinued care, which is a potentially high-risk scenario if the patient ignores recommendations, which can lead to increased morbidity, mortality, or readmission. Shifting gears slightly, moving forward, the data subset that we're looking at is those specifically with a substance use or an overdose-related code in one of those 30 discharge code fields among our unhoused patient zip code dataset. Same with the last analysis, we're looking specifically at non-fatal emergency department healthcare encounters. And the reason for this focus is that literature has established a bidirectional relationship surrounding substance use and housing instability. And what I mean by this is that chaotic substance use and substance use disorders can lead to the loss of employment and financial resources, as well as strained relationships with common support nets, such as family and friends, which could result in eviction or housing instability. Similarly, research also supports that living in unstable, harsh, or stressful environments, such as being homeless or experiencing housing instability, can increase the likelihood of substance initiation or even increase substance use in order to cope. And then compounding this, folks experiencing housing instability are more likely to report severe substance use consequences, such as overdose and infection. So it's a really layered issue. Digging deeper into the substance use disorder codes, which I touched on a little bit in the first part of the presentation, we see that they encompass a variety of presenting states, including abuse, dependence, and use, either uncomplicated, in remission, with intoxication, with withdrawal, or with a drug-induced disorder, as well as a wide variety of substances. By and far, alcohol-related disorders and nicotine dependence are the most prevalent codes within this list. And here's some more additional information on overdose codes, which are primarily what we'll focus on moving forward. These codes encompass a variety of intentionality, such as accidental, intentional, assault, or undetermined intent, as well as have a wide variety of substance involvement. These codes are not mutually exclusive, and so a single ED visit could be associated with multiple of these specific drug flags that are listed, as long as both or all of the substances are listed among any of the 30 diagnosis codes. A very similar chart to before, however, we're now focusing on this new data subset of substance use and overdose. And here are the 5 most prevalent primary diagnosis codes within that data subset. And you'll notice that the most prevalent codes did shift around a little bit in prevalence. The most prevalent primary diagnosis code for this data subset is that F10.120, alcohol abuse with intoxication, uncomplicated code that we saw second in the last list, I believe, and then unspecified under that. We also see stimulant and other psychoactive substance use codes. This F19 substance abuse, other psychoactive substance abuse uncomplicated code is usually used to refer to polysubstance misuse, where it's not possible to pinpoint just one drug that is causing a use disorder, or it's to denote the misuse of a substance that's not classified under those more specific categories that I showed you earlier, such as opioid use disorder or cocaine use disorder. And while it's no longer the most prevalent primary diagnosis code, the R45.851 suicidal ideations primary diagnosis code did show up on this prevalent list as well. And again, similarly to before, here are the 5 most prevalent discharge status codes, this time specifically within our unhoused patient indicator data subset that has a code for non-fatal overdose involving all drugs from the same study period, 2021 to 2024. And while the majority of these discharges are still routine at 80%, an increased percentage compared to just the broader unhoused patient zip code indicator data set were discharged or transferred to court or law enforcement, nearly 9% versus the 6.5% previously. We see that the psychiatric unit and psych hospital discharge or transfer code is as well at about 7%, and a relatively similar amount left against medical advice or discontinued care, slightly higher in this list at 5%. And a small number were discharged or transferred to custodial or supportive care facility. And to put this in context, I wanted to show y'all the comparison to the 5 most prevalent discharge status for the former non-fatal overdose surveillance data set for total drug non-fatal overdose for the same time period, which you may remember is the data set that previously excluded this unhoused patient indicator due to the state of residence variable coding error. So an interesting finding here is that less discharges are routine, 67% compared to 80%. More patients in this data set are transferred to a psychiatric hospital or psych unit than our unhoused patient indicator subset. So that's 20% versus 7% that we saw earlier. And less patients are discharged or transferred to court or law enforcement, about 3% versus 9%. And then you'll notice that the left against medical advice discharge code does not show up in the 5 most prevalent codes for the former non-fatal overdose surveillance data set, which is definitely a data point that we're keeping an eye on. Staying with that same data set, the former non-fatal overdose surveillance data set for non-fatal overdose associated with total drugs had about 10 to 12,000 records per year from 2021 to 2024. It's been slightly declining since 2021. And these are the trends that would be available on the non-fatal overdose dashboard that previously did not take into account the unhoused patients. Looking now at the same trend for our unhoused patient zip code data subset, we see that there are about 400 to 600 records added per year for non-fatal overdoses involving total drugs, with the addition of this data subset for the overdose surveillance. And that is representing about 5% of the total drug overdose surveillance population. So certainly adding important context here. We'll quickly look at some of the demographic differences between these two data sets that we've been discussing. First, looking at the sex distribution for total drug non-fatal overdose ED visits among the study period. And before we start, I do want to point out the differing axes on these charts, since the former non-fatal overdose surveillance data set is much larger than our unhoused patient indicator data set. But having said that, the former non-fatal overdose surveillance data set skewed slightly more female than male for non-fatal overdose involving all drugs. That's about 54%. And when we looked at the unhoused patient zip code indicator with overdose codes data subset, it skewed much more male, about 76%. And now comparing age distribution between the two non-fatal overdose surveillance data sets, we noticed that the youth category of 0 to 17 years is the most prevalent age group in the former non-fatal overdose surveillance subset that is looking at the trend for total drug overdose, with the next most prevalent group being the 25 to 34 year age group, about 20% prevalence, and almost 30% prevalence for that youth group. When we look at our unhoused patient zip code indicator subset with overdose codes, we see that that 25 through 34 year age group is the most prevalent, with that 35 to 54 year age group and being the next most prevalent, and a suppressed number of 17 and younger. And I do attribute this partly to the fact that housing instability and being unhoused can be a bit of a time to series event where we may not expect it to be one-to-one in terms of like encountering healthcare visits, if that makes sense. So, as I alluded to earlier in the presentation, not every ED visit record with the unhoused patient zip code indicator also has the Z59 code associated with housing instability. And not every ED visit with the Z59 housing instability code also has the unhoused patient zip code indicator. And this Venn diagram shows that. About 20,000 records within our study period had both the unhoused patient zip code indicator and the housing instability social determinant of health Z code. In the study period, about 75,000 records had the Z59 instability code, but not the unhoused patient zip code indicator, and about 65,000 had the unhoused patient zip code indicator, but not the Z59 code. And so when we were thinking about developing our definition for persons experiencing homelessness, we wanted to include both facets of this definition because we think that both are going to be an undercount. The zip code, for the reason that I mentioned, couch surfing or having an address to list for a shelter or a friend's house that you're staying at, you wouldn't get assigned that unhoused patient zip code indicator. And if you're vice versa, if your housing instability is not impacting your current healthcare visit explicitly, you're not going to get assigned that Z59 code. And so while we do expect this person's experiencing homelessness definition to be an undercount still, we felt it was our best bet to include the whole Venn diagram. So adding data for this person's experiencing homelessness indicator can help provide us some of that context around that relationship between substance use and housing instability that I was referencing earlier. So, lots of data thrown your way. Let's discuss it a little bit. We did notice notably different demographic and discharge status breakdowns when we looked at the different groups, which is an interesting observation for further research. I want to dig a little bit deeper and see what's going on there, as well as look at it by specific drug categories, because that really just starts to tell a much richer story as well. Looking at total drug overdose is a great way to look at the big picture, and especially for the purposes of a 30-minute presentation. But I'm very curious about how that's going to look in different substance categories. And including this unhoused patient zip code indicator is adding about 400 to 600 total non-fatal overdose ED visits per year, which, as I mentioned, is not nothing. It's about 5%. So really important context being added. And the addition of the persons experiencing homelessness indicator allows for increased consistency with other data sources. Often our non-fatal overdose data is presented in tandem with fatal overdose data, which already has a binary variable on the death certificate that collects data on whether the decedent was unhoused. So this allows us to be a little bit more intentional with our combining our data sources. So what now? Adding this new persons experiencing homelessness indicator on the non-fatal overdose dashboard that I manage is my next top priority. I have a final draft version that I'm running some quality assurance on, but should be publicly available soon. But to give you a little snapshot of what I saw when I started putting that together, first of all, the non-fatal overdose dashboard covers a broader time period, 2016 through 2024, rather than the 4 most recent years of data. After integrating the persons experiencing homelessness definition to the dashboard, about 8% of ED visits for non-fatal overdose involving all drugs were among Coloradans experiencing homelessness. Though geographic information is not always available for this variable because we had the patients with Z59 codes that did have county of residence information, there actually is a bit of geographic information, largely for our urban counties. And while we didn't dive into hospitalizations associated with non-fatal overdose in this presentation, that data is also available on the dashboard, and similarly have about 7% prevalence over the time period for Coloradans experiencing homelessness. So I'm going to work with other epidemiologists in the department that work with this Colorado Hospital Association data set for work in other relevant health topics, such as suicide and injury, since we saw especially since we saw such a prevalent primary diagnosis code for suicidal ideation. We want to figure out what's going on there. And data dissemination, of course. This analysis adds a lot of context to our existing ED visit data that we use for non-fatal overdose surveillance. And I'm working with the overdose prevention folks at the health department on disseminating this new data to communities and grantees around Colorado, and integrating that data to action piece to help inform work with resource distribution and outreach. And that's all I have for you. Thank you for your patience and your attention. And I would love to get in contact with you if this is a topic area that interests you at all, or if my broader work of substance use and overdose is at all interesting. I would love to connect with y'all.
Amazing. Thank you so much, Kylie. That was a really fascinating presentation. And I think we already have a few questions to get us going. For those of you who have already reacted in the chat, feel free to keep them coming with that applause. You can also raise your hand if you want to ask a question to unmute yourself. You can also type it in the chat. And I will get to it. But I am very selfishly going to start with one of my questions, but I might have some more later. I wanted to make sure, Kylie, you might have already addressed this, but in looking at the reasons for admission, we had alcohol abuse that was uncomplicated and also unspecified. Can you tell me a little bit about the difference between those two?
I will try. I'll give it my college effort. I'm really wishing my alcohol epidemiologist was on the call with me, Julia Stolkin. If any of y'all work with her, she's um, very talented at what she does. Um, you know what? I don't even know if I'll give it a college try because what I was about to do was Google it. I imagine that the uncomplicated piece. So here, let me go to a different slide actually for this.
That's okay if not totally sure. I think ultimately, they're probably very similar, and is further shocking of just the high percentage of alcohol abuse that we're seeing in this population. So that's great to know. Why don't I go ahead and jump? I'll jump to Logan has a question as well from El Paso County. Their question is this analysis possible on the county level? Since CHA data can come with a cost, do you think it's possible for local public health officials to adapt this approach to another data source like Essence? Hoping you know what that is. I'm not totally sure. That's syndromatic surveillance. Alternatively, if LPHAs could access this data, could the medical facility geographic variables be used to get a picture of non-fatal substance at the county level?
Yeah, really good question. I might address the second question first, just because it was a part of my analysis process that I didn't touch on here. I've been working on the injury epidemiologist Reagan Cavarini here at the health department on this analysis, and we had the same exact idea when we realized that the county of residence information was so sparse, and realizing that geographic information is a really key piece to community outreach and resource distribution. And so we started pulling the information together until we hit a roadblock in our data use agreement that we are not allowed to potentially identify any, not make the member hospital information potentially identifiable. So in urban counties where there's a lot of hospitals, that wouldn't be an issue, but in our more rural counties where there's only one, it would just be a non-starter. And so the answer to that second question is we wish we could have, but we understand why we can't. And we potentially could for the more urban counties, but it's typically our rural counties, right, where we're wanting some more information. So catch 22, I guess. But to answer your question, is this analysis possible on the county level? Yes, it will be, or yes, it is technically. As I kind of alluded to. So on the dashboard level, there will be limited geographic information for this variable. Part of the reason that is thinking about that Venn diagram of all the folks that had the unhoused patient zip code indicator of 0003, pretty much none of those records have geographic information. But because there were thousands of records with Z59 codes, a lot of those folks did have county of residence information. So it's a incomplete at the county level analysis, but it is at least a little more context than we had before. And you mentioned Essence. It's funny because, well, not funny, haha, but one of my inspirations for this project, or trying to really think about that person's experiencing homelessness definition, came from a syndromic surveillance dashboard here at CDPHE. And my coworker Reagan and I continuously revisited this dashboard so that we could make sure that we were using consistent language across the health department. I'm just pulling up the link for you there to show how they did it, because it's their heat-based illness dashboard. And so on the demographics tab of that, they have percent of their heat-related illness cases experiencing homelessness. And it's actually a surprisingly low amount. It's 4.5% for the heat-based illness. So I hope that answered your question, Logan. I'm certainly happy to connect with you offline about ways to help make this data useful.
Yeah, I think that was very helpful, at least for me. Thanks, Kylie. We have another question too coming in from Jessica. They want to know what data organization or organizations use that 003 zip code to identify homelessness. Or put another way, does CHA add in that zip code during data management to identify homelessness, or is it from source data? I do not know that I've noticed the 003 zip code in other contexts or in data before this.
So the first part of the question, I suppose I just touched on a little bit in that other project here at CDPHE that is using the unhoused patient zip code indicator in tandem with Zcodes. Does CHA add in the zip code during data management to identify homelessness, or is it in the source data? I'm honestly not quite sure about CHA's side of the process, and I can connect with my data manager contact over there and get an answer back to you, Jessica, because that's great. Like methodologic context, I think. If you'd like to connect offline.
Yeah, that would be great. Do you mind if I ask just a little bit of clarification? Is
Yeah,
that
of course.
okay? Yeah, I'm just wondering, like, I guess I have a lot of questions because I haven't heard about this before, and I'm happy to connect offline if that's okay with you. That would be great. Like if people who are entering the information, even at at the patient level, the hospital or whoever that enters it, do they know to use this zip code for their patients who are experiencing homelessness or um, and where did this all start? Who decided that was the zip code? I just have loads of questions. This is really cool. I'm glad that this is being tracked like this.
Yeah, thanks for the interest. And I know it's a little bit of a random indicator, like why did we choose the number three? But I wish I knew more about this sort of like this history of this coding practice because it would have been great context to add. And something that was, or I guess an effort that's part of my quality assurance that I'm doing before I publish the dashboard is sort of looking at this zip code indicator by certain uh, certain variables like hospital ID, I suppose, to see like if there's uniform up uptick of this. And I think, yeah, I guess thinking of it as an undercount gets kind of frustrating in that way, right? Because it's like how much of an undercount, but really, really great contextual information pieces that you're asking and kind of getting my brain gears going even some more. So I appreciate it.
I wanted to also highlight and ask Kylie about you talked about the people who were exiting that were going to court or entering law enforcement facilities because it was such a high percentage. I think you said 7% of the homeless identified population that you had, and then like 9% of um, the the ones that also had drug overdose involved. Is that right? Yeah,
Mm-hmm.
yeah. So I my under that seems really high to me. And my understanding is what is it? Law enforcement will sometimes bring people to the hospital for detox that have been arrested, and then immediately take them afterward, like to jail or to some other location type of thing. Do you know, is that kind of those are the people that are in this population, or are you able to tell like more about like what are these people that are being transferred to court? Um,
Yeah. Um, yeah, and it's kind of, I don't know what phrasing to use, like a cyclical thing, right? Where substance use is obviously criminalized, and then also being unhoused often is criminalized. And so it's this, not that I did an interactive or an interaction analysis, but interaction analysis, but it really does seem to be a multiplicative effect in this data set. Of course, we don't have the data to show that, but it was a stark number. Um, that said, we don't have a ton of information on, I guess, the reason why they were discharged or transferred to, X, Y, and Z. But I imagine that the scenario that you brought up would be a large percentage of folks are being brought in so that they can detox and have access to sort of that medical care before um, being brought into a jail system or to a court system.
Right. Right. Cool. Well, and I wanted to ask you mentioned also in your conclusion those big like demographic differences between the non-fatal overdose versus the fatal overdose with homelessness. I was curious, did you look at the population of homelessness that did not just include the fatals? Yeah, that one we're there. So like knowing, right, maybe if homelessness is predominantly male, whether that includes overdose or not, does that kind of shift? You get what I'm saying of like, are we seeing this sort of Venn diagram here with different differences?
I think I get what you're saying. Are you asking if like what the underlying population of this without the overdose codes? Yeah, I don't
Yes.
have the data for you off the top of I don't have the data available, but yeah, the as to the percentage skew, but it is more male than um, our ED visit data does, and the current surveillance infrastructure, or I guess the former surveillance infrastructure, that includes just all the ED visits, tends to skew more female anyway. Something about health-seeking behavior, sex differences, but yeah.
Yeah. All right. Well, we are hitting up right at the end of time for this session. So unless anyone has any final questions, if they want to raise their hand, feel free. I'm going to start to do some wrap up. Thank you guys so much for attending this session and for engaging in the Q&A. Some final announcements: the slides and any additional handouts speakers have provided are available on Sketch. You also will receive a conference evaluation form via email after the conference. Please fill that out. Even if you only attend a portion of the conference, it's really helpful for our planning committee just to know what you guys thought. And this concludes all of the presentations for today's session of the Culture of Data Conference. Tomorrow's schedule begins at 9 a.m. with our keynote speaker. Be sure to see all of tomorrow's sessions on the Culture of Data Conference website. And thank you all again for attending today. So thank you.